So I'm going to do the first part, and we've got 12 minutes. Apparently we've got twice as many slides as anybody else. And the reason we have twice as many slides is that we hit the ground running with this. This is the work I'm going to present is co-funded by the National Science Challenge and HRC, but actually also the Heart Foundation. I really apologise to the Heart Foundation for not putting it on the slide, because they are also a major funder of this work. In fact, most of the slides Jerry presented, which come from ANZAC's QI, is part of the VIEW program. And VIEW stands for Vascular Informatics Using Epidemiology and the Web, and it's a program we've been running since, we really started back in about 2001. And our main focus is more accurate risk prediction, better risk management, and the goal is to reduce inequalities in vascular disease burden. And a number of people have talked about the sort of mantra of the National Science Challenge is the right treatment for the right patient and the right prevention for the right population. We do, certainly in vascular disease management, we pretty much know what to do, but when it comes to management of individuals, we don't know which ones to give it to. And so a lot of the work that I've been doing recently is developing risk prediction tools, and Malcolm and others are doing as well, so that we can actually focus and target the treatment to the right people. The National Science Challenge has allowed us to focus specifically on Māori, Pacific and Indian peoples. And again, we're focusing on better risk prediction for these populations, better risk management for these populations. And of course, the underlying goal is to reduce inequalities. And I'm going to talk mainly about risk prediction today. So many of you will know that in New Zealand, for many years, we have been attempting to target treatment and prime prevention to people at highest risk, and we have these national cardiovascular risk charts. We don't seldom use charts anymore. It's all electronic, which is great, but this is where it started. And so, for example, if you had a male patient who was, say, age 50 and with no diabetes and a non-smoker, so it's this little box here. So if that patient has a blood pressure of 150, systolic, and their total cholesterol to HDL ratio is 6, what this chart tells you is that out of 100 men like him, about 5 will have a heart attack or stroke or some other cardiovascular event in the next 5 years. So that's what this was designed to do. And why do we want to do that? Why do we want to predict the risk? Well, most of our standard treatments, our standard treatments in prime prevention can halve someone's risk of a cardiovascular event within 5 years. So that means that if this man had a 5-year risk of 5%, we can halve it to 2.5%. But if his older brother, who also was a smoker, had a risk of 10%, the same intervention would halve it to 5%. And maybe if his very old sister, who also had diabetes, had a risk of 20%, we would get an even bigger benefit. So the whole point of risk prediction is that the pre-treatment estimated risk actually determines the magnitude of the treatment benefit. So it's more cost effective to treat people up here, okay, with more intensive interventions. We treat everybody, but more intensive at the high risk end. Okay, so the risk prediction tools that we use in New Zealand are based on data from the Framingham Heart Study in the US. So about 5,700 men and women were assessed. This is an ongoing study, ongoing since the 1950s, but the data we use was collected in the late 60s up to the mid-70s, and they were followed for about 12 years. And the data from that part of this cohort was used to develop the New Zealand risk prediction equations. We started using these in the early 90s, and when I looked for data to use when I developed the first charts in the early 90s, this was the best data worldwide. Okay. The question, of course, now is how relevant is data from the 1970s in a white US population. But made the point, that's all we had. But how relevant is that to New Zealand, to the 21st century, and to a multi-ethnic population? That's the question. The other question a more specific question, is that when we developed these charts, and we knew that Māori, Pacific and South Asians, well, we assumed that they had a risk over and above the standard risk factors. And when we had these charts, when we first developed them, we kind of took our best guess and we said that if you predict risk using this chart, add 5% for people Māori, Pacific and South Asian, because that was our best guess at their risk over and above the standard risk of other people. So that's where we were around the beginning of 2000s. And so there's a question, is that correct? And at the time, it was the best we could do. So in about 2000, I established a program of research called Predict. Not an acronym, it's just about predicting risk. And what Predict did is, the first thing it did is that it attempted to facilitate the implementation of national guidelines. So basically, national guidelines said predict everyone's risk. So if you're in primary care, predict their risk and use that risk to determine treatment decisions. So part one of Predict was actually as a clinical tool to facilitate management. But part two of Predict was to simultaneously generate new risk prediction equations. So we were doing both, developed a clinical tool and a research tool all in one. And so what happened is when a GP or practice nurse was risk assessing their patient, a copy of the data went onto this Predict server. It was all encrypted, went onto the server. Now, of course, in the background in New Zealand, because of the NHI, because of our data, if anyone in New Zealand has a hospitalisation or a death, their data goes into a Ministry of Health server. So what do? We asked the ministry if we could take the data from their server on these patients, put it onto the Predict server, link them up using the encrypted NHI, and replace the framing equation with a New Zealand equation. So that's what we've been doing for the last 10 to 15 years. Okay, this is our data. We introduced Predict into ProCare in 2002. It's used now by about 1/3 of New Zealand GPs, and we have 500,000 people in Predict. What we link it to, Predict data gets links to hospitalisations, the data that Tony talked about, to deaths, to regional labs, to PHO enrolments, and to the National Drugs Database. And it's all done using an encrypted NHI. These are the numbers that we've been using to develop new risk prediction equations. 219,000 men, 168,000 women. And look at these numbers here. Māori men, 26,000, Māori women, 22,000. So you look at the numbers there, all of those numbers are much bigger than the total Framingham population, okay? Outcomes, I don't want to dwell on this, but we've got almost 13,500 outcomes. Framingham only had 5,500 participants. So we've got quite big numbers, okay? So far, we've got 1.5 million person years of follow-up, almost 4 years average follow-up, but a lot of people have been followed for longer. And so what have we found? Okay, so we've answered our first question. Remember I said that currently, if you're Māori, Pacific or South Asian, we add 5% risk to your five-year risk prediction. Okay, what do we show? Well, what we show is after you adjust for all of the standard risk factors, yes, being Māori, being Pacific and being South Asian, and in New Zealand, most of the South Asians are Indians, and just the way we code data means that we have data on Indians, that Māori men have about a 40% increased risk of cardiovascular disease over and above the standard risk factors. Māori women, it's about 50%. For Pacific people, it's about a 25% risk over and above. And for Indians, for men, it's about a 40%, and for women, it's just over 20%. If you're Asian, as you know, you have a reduced risk, about a 25% reduction in risk. Another risk factor, for every quintile increase in socioeconomic deprivation, there's a 7% increase in risk over and above all of the other risk factors, okay? And just a couple of others, the standard thing. Smoking increases your risk by about 75% of men, almost double in women. Diabetes increases your risk by 50%. All the standard risk factors, that's kind of what... So these are going into new risk prediction equations. Now, what we're planning to do for the National Science Challenge part of this is we were going to stop here But what we can now do, because of the National Science Challenge, is that we can develop separate equations for Māori, for Pacific, and for South Asians as we get the data. Because at the moment, even though we've made a major step forward in terms of risk prediction, in that we're just not giving everybody, every Māori, Pacific, and South Asian a 5% increment, at the moment we're going to give every Māori male a 40% risk, increase in risk. So our next step is to develop specific equations for Māori, Pacific, and South Asians. Now, to help us work through this, we've been looking at our data. So we've got 500,000 people approximately assessed in primary care. This is people 30 to 74 years of age. This is just cut down by age group, but just a couple of key things. Māori men, 34% of 35 to 74-year-olds are smoking. Māori women, 37%. Pacific men, 27%. Pacific women, 16%. And so you kind of know some of this data, but this is actual data from primary care. Scarily, if you look at BMI over 30, Māori, 60% of men, 58% of women, 75% of Pacific men, 79% of Pacific women, 20% of Indian men, etc. So these are the actual data from primary care. And diabetes, which follows on, 20% of Māori men, 22% of Māori women, 37% of Pacific women. Look at Indian people. And other Asian people, Europeans seem to be protected from diabetes compared to everybody else. So that's the main work that we're doing, but I just want to touch on two other projects. I've not quite used my 12 minutes, as we're going to follow on. We have two other major programs related to the Science Challenge. One is called VariANZ, which is a project where we kind of do the IDI just using health data. If you link all of the national health data sets, you have this health contact population. We've put together a cohort of everybody who had some contact with the health sector in 2006, okay? Call it VariANZ. Now we've got fairly large numbers, 2.5 million people. We are about 15% less than the census, but hey, 85% response rate of the total New Zealand population. You put all those cohorts together, you create a cohort, you follow them for 5 years, and we can actually do a new risk prediction equation. So we're doing one in primary care called Predict, which we're using, it's going to be used by clinicians. We've developed one that's only based on routine data that is designed for policymakers. And what we're planning to do is to develop a policymaker's risk prediction equation that they can apply to everybody in the country. So we can give every adult New Zealander a risk just using routine data and then look at how their treatment is managed related to this. Okay. And my final slide is that we're doing a new version of this called VariANZ IDI using all the data sets that Tony talked about. And we've pretty much done this. And so we do all the same thing, but then we add all of the other databases. So it's a VariANZ Plus, and we've got over 3 million people in this cohort aged 20 and over, and we've got 4% more people in the census. So this is the total New Zealand population, and so we're going to use this to do the same thing. So that's what we're up to, okay, so far. Okay, over to you, Malcolm.